So today we're going to be talking about neonatal sepsis. It's going to be the major part of it. And we hopefully will have time to go also through some common conditions that we are approaching, specifically with some job aids. So we will start with some concepts and history, the epidemiology briefly, antibiotic treatment and overtreatment, diagnosis and trends, management, prevention, common conditions, and discussion. So just going back to history, sepsis and infection has been always an issue in the history of humanity. And in the past, there are medical theories that are recorded from 500 before Christ, and also some similar theories from Indian Ayurveda medicine. And even Hippocrates had published in the Nature of Man, trying to understand what sepsis, and it would be described as an imbalance, basically, of humors in the body, which was very interesting as theory. So now what do we know about neonatal sepsis? Up to today, we don't have a real definition of neonatal sepsis, a definition that is a consensus before with everyone. We are going to use alternatively, proposing this definition that's definition that's been published in the JAMA 2024. It would be a life-threatening organ dysfunction caused by infection. This would be the definition of sepsis, but actually it could be many other definitions. There is also no definition of septic shock, and alternatively it could be sepsis in patients with manifested cardiovascular dysfunction with associated higher mortality, which is more like an epidemiological description than a definition itself. And we will use the concept of bacterial infection in the continuum of care to talk about sepsis, knowing that sepsis can be also viral or fungal, or a fungi can also cause sepsis, but most of it, the big bulk of it, will be talking about mostly bacterial infection. So the case fatality rate is very high in real cases of sepsis, especially in low and low middle income countries, especially low income countries. They have a case fatality rate of 25%. And this is in cases registered with positive blood culture. So it's an important case fatality rate. And we know that sepsis is not only causing a lot of deaths per year. So we have about 3.9 million cases of sepsis, neonatal sepsis per year in the world, with a different rate that has been described, considering proved infection and unproved infection, but there is a rate about 300,000 deaths per year, and with a major mortality and long-term disability associated to sepsis. So it's not only the sepsis that causes the infection, we treat the infection, and the infection is gone, everything's fine, but every episode of sepsis carries a high risk of disability and mortality. And preterm babies and low birth weight babies, they have 3 to 10 times higher risk of sepsis. And we see in this figure that actually this loss, this DALIs, as this major mortality and long-term disability is seen mostly in sub-Saharan Africa. That's the red ones. That's where we have the highest DALI, and also Southeast Asia. And the risk of infection is not only one point, so there is a high risk of sepsis, and you have a high risk of infection, morbidity, neurological disability, and death. But there is also a high risk of infection in the childhood. So this doesn't stop, especially when you're talking about preterm babies. You can see that, for example, these are less than 28 weekers, the blue ones. This is age of admission, so they are admitted at birth, and they are still at higher risk at 1 year old, at 3 years old, at 5 years old. And of course, the lowest the gestational age at birth, the highest the risk they will carry through life. But every gestational age, they will carry higher risk until about 7 years. So when you talk about the disease itself, so neonatal sepsis is not just one, it's more than one. We usually define early onset sepsis and late onset sepsis, but maybe we could even divide into diseases, early onset sepsis, late onset sepsis, that's hospital acquired and that's community acquired. When you look at global data, we see that the early onset sepsis, that's the global is this one, early onset sepsis is the orange one. And when we see the incidence of early onset sepsis through years, so starting in 1900 up to 2020, about 2019, we see that it's been basically stable. We have much more early onset sepsis diagnosed. The incidence is much higher than the late onset sepsis in the world. And when you take low income countries, we see that this trend is still there, much more early onset sepsis, but a trend that is still going up. Whereas in some other countries, it's stabilized. In low income countries, still going up. This data is defined by clinical diagnosis, mostly clinical diagnosis or bacterial diagnosis. And then we're not sure if all of these cases would be confirmed, but the cases that are suspected of sepsis are still increasing basically in low-income countries as reported. Early onset sepsis is mostly an ascendant infection, so it's usually caused by a maternal infection, maternal colonization. The mother has the bacteria, and the barrier between the mother and the baby, or during delivery, the baby gets colonized with the same bacteria that the mother has. And once the baby gets colonized, he can become infected. And this can happen intrauterus. It can happen just at the moment of birth. It can manifest signs of infection, or usually in the first 72 hours. And late onset sepsis will happen after these 72 hours, can be hospital acquired. Most of these hospital acquired infections, when you have a device, it's device associated, but it can also happen through other sources. For example, hygiene, other kinds of issues with hygiene. And they can also be community acquired, so basically based on community contact. So 2 or 3 diseases. So if you go in early onset sepsis, what are the risks? So the main risk for early onset sepsis are prematurity, premature ruptures of membranes that's prolonged more than 18 hours. And this is simple to understand because the more the baby stays there without the membranes, he'll be likely to be colonized with maternal bacteria. And once he's colonized with pathogenic bacteria, he has a higher risk of being infected. Foul-smelling amniotic fluid, because this can be a sign of coimmunitics, of basically pus. Maternal fever, more than 38 degrees, multiple or unclean vaginal examination, because when every new vaginal examination, especially when the membranes are ruptured, is a risk of infection. First, you are mobilizing bacteria from the vagina, but there is also unclean. So if there is a problem with hand hygiene, the staff doesn't have clean hands, this can be a source of infection to the baby, to the fetus. Maternal colonization. So mothers that are colonized with group B streptococci, these are GBS. This is a major bacteria in neonatal sepsis, as of course all of you know. For hospital acquired, we have as main risk prematurity. Prematurity is always a big risk, and we are just spot on in our population, basically, that's so much at higher risk of infection at all periods. Prematurity, central or peripheral lines, tubes, poor hand hygiene, it's a must, it's a major issue. And poor hand hygiene is what's contributing basically to a big part of the central or peripheral line infection, to the tubes infection, and to the susceptibility and to increasing, basically colonizing these premature babies that are more susceptible and getting contact to unclean or hands that are carrying pathogenic bacteria. Previous antibiotics, they change the microbiome, and this increases the risk of infection for premature, especially premature babies. Poor umbilical care, of course, there is a risk of transmitting directly from the umbilicus. Delayed feeding, and we'll talk about that later. Community acquired, so also again, prematurity is still a risk for community acquired infection. Poor hand hygiene, previous antibiotics, poor umbilical care, also delayed feeding and contact with sick people. So they are very close basically, but it's happening in different places. So the ecology will be different. So again, Temporality is basically a convention. Less than 3 days of life, early onset sepsis, more than 3 days of life, late onset sepsis. But there is a plausibility behind that. The time for colonization, it will take about 36 hours. So, and then you have to manifest the infection. So what are the diagnoses? How we diagnose sepsis? Again, all of you know that so many symptoms, so variable presentations. So we can have systemic presentations in basically all systems. Tachycardia, bradycardia, gray skin color, capillary refill, increased signs of shock, basically. Respiratory-wise, tachypnea, chest retractions, nasal flaring, grunting, apnea, and also bradyapnea, which is like precursor of apnea. Temperature instability, it's a big one, especially for preterms. Cold extremities, unstable temperature or fever. Preterms, reminder, they will have a tendency to become hypothermic when they are infected. Digestive system, so vomiting, feeding intolerance, feeding refusal, lethargy, like more neurological symptoms also, lethargy, hypotonia, seizures, and also hematological that are not uncommon, especially in severe sepsis, bleeding, disseminated intravascular coagulation, and jaundice can also happen in babies that present with jaundice. So the definitive diagnosis of sepsis is definitely blood culture. That's easy to say, and it's a big problem also. It's a big challenge, we all know. It's a big challenge in availability of blood culture, also in price, in volume, and in technique. So this has been a major issue reported in low and lower middle-income countries. To start with blood cultures, they are best practice for doing blood culture. So if you don't do a blood culture, if you perform a blood culture to start, if we can perform a blood culture, it should be performed in the right way. So with correct disinfection, the topical disinfectant may vary according to gestational age. Some people use different one for small preterms, but we need to do a disinfection, and we need to wait for the disinfectant to dry and to act. And we cannot repalpate the place where we're going to prick, of course, before doing the blood culture. The site, so it should be obtained for a peripheral site, arterial venous puncture. If a catheter is present and there is a suspicion of catheter-associated infection, it can be also aspirated from the catheter. And also, well, for a central catheter, the catheter can also go for culture. But ideally, peripheral blood culture should be taken. And the volume. So the volume is a big challenge because we need 1 milliliter of blood culture. That's the recommendation. An extra milliliter of blood culture volume, you have 63% probability of pathogen detection at a very, very low, the minimal detected amount of bacteria per milliliter. This reduces a lot when you use 0.5. It comes from 63 to 39%, and from 0.5 down, it's really, really low. So blood cultures with very, very low amounts of blood, they will have a much less positivity-based probability of detect the pathogen. So this is very important to do the blood culture with the right disinfection and with the right amount of blood. And usually we will find a different bacteria. So this is just a more large of a thing. In lower and lower middle income countries, there are different pathogens that have been reported from high income countries. And there are many protocols, and sometimes when we work in high income countries, we tend to think that way. But this is very important to know that these bacteria, they are different, they have a different profile. And of course, ideally, we should know what our region has to tackle it better. Regardless, we have the protocols that will cover gram-negative, this gram-negative enteric bacteria, gram-positive, and when you suspect of Staphylococcus, you should target on Staphylococcus species. So there is a big diagnostic gap in low and lower middle-income countries is concerning blood culture and antibiotic therapy. So again, we're talking about the first challenge, the volume, the disinfection, so doing the right blood culture. And now the challenge is, of course, availability of blood culture, and sometimes it's price of blood culture. And we see that many babies, they don't receive blood culture before starting treatment or during the whole treatment, or even during new episodes of suspected bacteremia. So this is data put from NEST 360 in Malawi, Kenya, Tanzania, and Nigeria. And we see on the blue, dark blue one, the number of admissions of babies. Here you have the total numbers. It's a very, very large numbers. And we have the clinical infection diagnosis. So diagnosis of sepsis based only on clinical pathogens. And we see that not everyone. In some countries we have low, like for example in Malawi, but some countries like Nigeria, we have 69%. And then when we go for blood culture done, it's a small blue one. So regardless the country, you can see here, for example, in Malawi, almost no baby receives blood culture. And we see all of the countries have a low number of blood cultures related to the number of suspected cases. And when you see the number of babies that receive antibiotics, is the pink one, it's much, much higher than even the clinical infection diagnosis. So many babies even receive antibiotics without clinical suspicion of sepsis. And basically a large part of them don't have blood culture. And this is a profile that we can see in many, many countries. So this is a survey we did in sub-Saharan Africa in different countries. And it was reported by health professionals. Use of antibiotics on admission about 86% for any newborn, with a high likelihood of 63% for a second full course. And 82% of these babies that start antibiotic, they would receive at least one full course. When you look at our data, so we see SIR data, so these are the 4 countries, and basically I'm not going through details, but basically just to show the antibiotic usage during the hospital admission, and this is time. This is the percent of admission days of antibiotics, and we see that many of our babies, 100%, that's these lines on the top, they receive antibiotics. So it means if they say 10 days, they will have 10 days of antibiotics. Some of them, they will have less, as you see here. Some babies they didn't receive. And this is only babies less than 34 weeks or 2 kilos. So only preterm or very small babies. And many of them, so a large part of them, they will always be on the top. You see this dark gray area, receiving a good amount of antibiotics during the whole admission. So we have a large antibiotic usage ratio in our sites. So antibiotics effects in neonates, they affect the microbiome. Microbiome favors growth of pathogenic flora, increased risk of infection and NEC, especially in preterms if you basically disturb your microbiome, up to 20% higher risk of NEC by an additional day of antibiotic without confirmed infection. There is also a long-lasting impact on growth and chronic disease in these babies. And basically 48 hours of antibiotic can change the microbiome for 1 month. Imagine 10 days. So what can be used when blood cultures are not available? Biomarkers? Well, what is a good biomarker? A good biomarker is a biomarker that has high sensitivity to avoid missing a true case, and that has high specificity to prevent unnecessary antibiotic exposure. There are several neonatal biomarkers for sepsis that have been studied through the whole history of neonatology, and none of them has been proved a good biomarker, unfortunately. So what can be used? What do we use right now? What do we do, basically? So there are things that are available in many places. And basically, what's mostly available in most of the places are clinical diagnosis. So clinical diagnosis is basically a fundamental basis of treating and of diagnosing and of any kind of care in general, including sepsis. So clinical diagnosis will mean, by this I mean history, antenatal and perinatal history, and clinical signs. So basically we can think about risk factor plus clinical presentation. For example, we have 2 cases here. We have for case 1, it's a 35-week neonate that had a non-elective cesarean section. So it was an emergency cesarean section for maternal severe preeclampsia, so maternal reason. And had an artificial rupture of membranes during the surgery. Apologies for the typo. maternal obesity with respiratory distress at birth that improved with CPAP. The baby is well appearing. The second babe is a 35-week neonate, precipitous birth. He had a premature, prolonged rupture of membrane of 48 hours. There is a foul amniotic fluid, foul-smelling amniotic fluid. Maternal temperature is 38 degrees. GBS is unknown. There is no maternal antibiotics. The baby is born, is tachycardic, and has a CRT of 3 seconds. So when you look at these cases, I'll let you answer in the chat. Which one would you start antibiotics? 1, 2, or both of them?
2.
2. I had an answer.
Second one.
You can write in
two.
the chat. Yes, thank you. I have another said 2. Don't hesitate if you start for baby 1. Also, most of people would start for baby 1, so don't hesitate if you would also choose. So maybe most of the people are answering in the chat baby 2, which is definitely, this baby has everything, right? This baby has everything. It has all the factors, all risk factors for sepsis, plus it's a preterm, plus you have a clinical condition. So you have tachycardia and you have an increased CRT. The second baby, it's like a clean birth, right? So this baby came from a cesarean section. The mother was just sick because of preeclampsia. It's a fetus that was previously well. You don't have prolonged ruptures of membranes. You have maternal obesity. So this, we don't know, but maybe obesity, maybe should have some insulin resistance, maybe should be diabetic too. Unsure, but maybe. The baby has respiratory distress and only respiratory distress. So a baby that comes from a clean birth that has only respiratory distress, no other risk factors, and is well appearing, and we put the baby on CPAP, the baby gets better. Well, sounds less like sepsis, right? Of course, many guidelines would start antibiotics, and this is not a problem, starting antibiotics for this baby. What's a problem is not stopping antibiotics or giving too prolonged antibiotics. When you start treating, the baby gets better very fast. Let's say this baby, you could stop CPAP in 2-3 hours. The baby's well, feeding, no symptoms, nothing. Well, this baby would be a candidate definitely to stop antibiotics if it was started. Whereas the second one definitely sounds much more like he's infected, unless we proved otherwise. So clinical presentation is very important, and then we saw many babies in low-income countries are being treated even without symptoms, and this is something that can be targeted basically. So when we talk about risk, we see that this baby, the first one, has low risk. What's obstetric indications of preterm birth? So we had maternal indication, there was a cesarean delivery, there is an absence of labor. And this, according to, well, there are different guidelines. I just took at this a more recent reference from American Academy of Pediatrics. There's two, they say that there are 2 initial acceptable approaches: no laboratory evaluation and no empirical antibiotics don't do anything, or do blood culture and clinical monitoring could be fine. And again, many other sites would start antibiotics and stop earlier, which is also fine. Not ideal, but also fine. The thing is, the thought behind it is just not to treat or not to prolong treatment in a baby that doesn't look infected, doesn't have signs of infection, doesn't have risk of infection, and that could be harmful. This one here, the second baby, was born preterm because of piprom and chorioamnionitis. This baby had chorioamnionitis. So in this case, of course, needs antibiotics. So some sites will have also hematological tests. So the most common is CBC, and what will be used as biomarker will be the neutrophil count or the IT ratio. These, well, in general, CBC is a very low sensitive marker for early onset sepsis. It's also not very good for late onset sepsis. And basically, there is a lot of variation with the neutrophil count and with the CBC itself, with gestational age, sex, delivery mode, and no infections factors like preeclampsia, which was this case. Placental insufficiency, prolonged inflammatory case like PRON. So CBC components perform poorly in predicting early onset sepsis, including in infants less than 34 weeks. So only extreme values meaningfully increase risk. So what could increase a little bit the risk, could give you an idea, could give us, okay, this baby might be infected, is full blood count of less than 1,000, ANC of less than 1,000, and IT ratio more than 0.25. Some modest associations are full blood count very high, so leukocytosis more than 50,000, and platelets low, very low, less than 50,000. So basically, CBC abnormalities alone are not reliable predictors of early onset sepsis. Only extremely values will increase risk of sepsis itself. CRP, PCT, so many sites have CRP specifically, not PCT. So CRP and PCT both increase in inflammatory conditions, including infection, asphyxia, pneumothorax, or instrumental delivery with subgaleal hematoma, or sometimes even a large caput can increase CRP. So single values of CRP and procalcitonin obtained after birth to assess the risk of early onset sepsis are not sufficiently sensitive nor specific to guide early onset sepsis care decisions. Now, normal serious CRP or PCT measurements with the first 36 hours after they start antibiotic therapy can exclude the presence of early onset sepsis with a high probability. So it's a possibility where you don't have a blood culture and you have serial CRP, for example, that is negative in a baby that is well. Of course, if that is sick, there is always a risk, but a baby that is well, there is a negative predictive value very, very high. So it's very low probability, basically, that a baby would be infected with negative serial CRP. So this is just quickly data from an NLP. It's a very large multicentric study that evaluated following up antibiotics with guided CRP and PCT, especially PCT. But they did a secondary analysis and they looked at the predictive positive value, basically, of this CRP, PCT, and full blood count. And basically, the CRP and the PCT were very high for sepsis versus proven sepsis, no sepsis versus proven sepsis, no sepsis versus probable sepsis, and no sepsis versus uncertain sepsis. But the full blood count was always very low, especially this one, no sepsis versus proven sepsis. So there are other organ-targeted tests, of course, especially in late onset sepsis, which we have been talking basically only about bacteremia. And now we'll be talking about also organ-targeted infection. So NEC. Necrotizing enterocolitis, if you're suspecting of necrotizing enterocolitis, an abdominal X-ray, of course, if it's possible to do, it's also good to have. NEC, we will be suspecting there's a late onset infection in extreme preterms or hypoxic babies, those babies that are very hypoxic at birth or have congenital cardiac disease, that after feeding, they will have a gastrointestinal symptoms with systemic symptoms. So this is the order basically of symptoms that we might have. So basically NEC, you always have gastrointestinal symptoms, and then you have systemic symptoms after that. You can have all of them. Meningitis, one suspect meningitis. So well, we recommend, WHO recommends to do lumbar puncture, suspected meningitis, and AAP also recommends that, of course, if possible to do and to analyze the CSF. When to suspect, when you have a drowsy, lethargic, convulsing with bulging fontanelle, irritable, high-pitched cry. So we have a baby that has neurologic symptoms and systemic symptoms, or sometimes isolated neurologically symptoms with just temperature instability, for example, suspect meningitis. Pneumonia. So pneumonia, you can also do a chest X-ray, and if available, suspected pneumonia, or if you have a baby that you suspect infection that has severe respiratory distress, oxygen dependency, you can also exclude other causes for the respiratory distress. And you always have respiratory symptoms in these cases. So there are also other kinds of late onset sepsis, like catheter associated. Of course, if you have a catheter, especially if it's a long time, even peripheral catheters, they can get infected. So very important to have a look at the catheter, see how it's around, have a look of how long this catheter is there. So it's always suspected a catheter. Whenever possible, and there is no other inflammation, there is no other explanation. So also include the UTI. So just think about UTI, and when you don't have any other symptoms, especially. So UTI is also a possibility as late onset infection in neonates. Not many people will be able to do it. That's all right, but just to mention again, and this is very important. And this is something that any person who is working with neonates that has a baby, especially that has a late onset infection, should do. When baby arrives, he should have a complete physical examination looking for a source of infection. And this should include bones and joints, thinking about osteomyelitis and arthritis, septic arthritis. All right. So we have a sepsis job aid. So this is, we're going to go through it right now. So basically the job aid has everything that we have been looking at right now. So early onset sepsis, we have the definitions here. We start with definitions, early onset sepsis and late onset sepsis. So first 3 days, then we have the risk factors that we spoke about. Late onset sepsis after 3 days related to hospital community environment. And then we have the risk factors. Then we talk about clinical presentation, so all the symptoms we spoke about here. And then, again, recommendation, clinical signs with no other explanation, baby has blood culture, and treatment for sepsis. Important thing, once decision is made to treat, antibiotics should start and given in 1 hour. But before antibiotics, again, have to do blood cultures whenever it's available. If it's not available, antibiotics in the first hour, but whenever blood culture is available, it should be done whenever possible. Important for prophylactic antibiotics are not recommended to prevent bacterial infection in neonates, only treat babies that are symptomatic, and antibiotics change the gut microbiome, which increases the risk of further infection of neck and of associated chronic disease in adulthood. So clinical guidance. If the infection focuses on the skin, umbilicus, joints, or bone, and the infant has systemic symptoms, always suspect Staphylococcus sepsis. And if the infant presents mainly with neurological signs, lethargy, irritability, seizures, bulging fontanelle, perform lumbar puncture and treat as meningitis. If meningitis is not possible, if LP is not possible, treat as meningitis. So again, blood cultures are gold standard for sepsis. If blood culture is negative on an improved baby, stop antibiotics. Positive CRP does not confirm sepsis. Negative CRP after 36, 48 hours of symptoms is in an improved baby can be used to stop antibiotics treatment in absence of blood cultures in this project. And then we have the antibiotic choice. I'm not going to go through details on the doses and the timing, but this is basically WHO guidance. And we always, for sepsis, we use ampicillin and gentamicin. For meningitis, we can use ampicillin IV or cefotaxime IV, or ampicillin IV or ceftriaxone IV if you don't have cefotaxime, plus gentamicin. For suspected pneumonia, ampicillin and gentamicin. And for suspected staphylococcus, sepsis, or ophthalitis, cloxacillin and gentamicin. Guidance for gentamicin in preterms. So we have a corrected dose. So gentamicin is ototoxic and nephrotoxic. So for gentamicin, we have some guidance for preterms to do for less than 35 weeks every 48 hours and more than 35 weeks, 24 hours. And we suggest considering stop gentamicin after 5 or 7 days. Okay, let's go through the prevention. So we talked a lot about microbiome. Microbiome is very important. It's a target basically for prevention, and microbiome is disrupted, you have an increased risk. So what if we can restore microbiome? So Vaginal microbiome, there are no interventions on vaginal microbiome that can reduce the risk of preterm birth or of infection. So neonatal colonization starts promptly at birth. But feeding, so we know that breastfeeding reverses faster microbiome perturbations caused by cesarean section. Preterm formula fed babies have lower microbiota abundance than mothers on milk babies. So mothers on milk basically protects the microbiome. High risk of NEC in formula fed, and this is a consensus. This has been proved again and again. Babies that are fed with formula, preterm babies, they have higher risk of NEC compared with babies fed with mothers on milk. So there are also other protective factors like probiotics. So this has been proved to reduce the late onset sepsis about 15%. Lactoferrin, there are contradictory information. It might reduce late onset sepsis about 18%. So lactoferrin is basically an anti-inflammatory, immunomodulatory protein that we can also find in the mother's own milk, in human milk. And actually 150 milliliters per kilo per day of mothers on milk, so a baby that is on full feeds, has about 1 gram, so 1,000 milligrams of lactoferrin. And also, we see that the babies that are fed with mothers on milk have a healthier microbiome. So basically, mom is the best. Mothers on milk is basically really, we can see how it's really protective to the babies, also concerning infection. KMC. So KMC reduces the risk of infection about by 60% in neonates. So this has again been proved again and again. And we know also that IKMC reduces the infection around extra 20%. So we have even an extra added value on reduction of infection. So we have tested so many things. There are so many drugs and so many therapies that have been tried and tried all over again and are still being tried to prevent or to modulate sepsis. And basically 2 very simple things, mothers on milk and KMC, they have been proven to do that. Of course, hand hygiene. So hand hygiene reduces the mortality and infections in the NICU. Again, just remind the 5 moments of hand hygiene, very important. Should just keep remembering that. Hand hygiene also should be performed after and before and after wearing gloves. So this is a message that's very important to staff when you are mentoring them. And there is a Cochrane on trying to measure the difference of the impact of hand hygiene in antiseptic soap and alcohol. Didn't find any statistical difference, so it's not proved yet what's best. But we know that, soap, with soap you can take out the dirt, basically from the hands. With alcohol and antiseptic, they should only be used with hands that don't have dirt, basically that are not soiled. IPC, so we already have the IPC seminar, and we already talked about bundles, and basically IPC, it's a very, very extremely important strategy to reduce infection in the NICU, late onset infection. There are some studies on natural oil. So there is a study of coconut oil that just show the results in a congress in Australia, and it was not effective to reduce neonatal sepsis. And there are some studies being done still on oropharyngeal colostrum. This could be something that will have an impact, but it's not being proved yet. We have different values in different studies. So it's not recommended yet as routine care. Not for this purpose, but of course, this baby should receive colostrum. And again, we can always give small drops of colostrum for babies as a whole bundle of care. So still many gaps on sepsis, gaps on preterm birth prevention, gaps on prevention of sepsis, gaps on detection, gaps on antibiotic therapy, on monitoring, and on additional therapy. We know some things, but we don't know a lot. Still to also try to improve a detection with a method that will be available worldwide. In conclusion, once suspected sepsis, of course, treat fast, perform blood culture before start antibiotics with the correct technique, and treat in less than 1 hour. Once excluded, stop antibiotics. reduce antibiotic exposure, and do not treat babies more than necessary because this is harmful. And prevent saving third-party care, IPC, catheter care, skin care, breastfeeding, KMC, reduced antibiotic exposure, especially for preterms. So we finished the sepsis part. Maybe we could have a round of about 10 minutes or 15 minutes of discussion, and then I can show, we can go through the management of common conditions. If you agree, what do you think, Marian?
Should be fine. Thank you, Flavia. Can you hear me?
Yes.
Yeah.
Any comment?
So any comments or questions? Let me just check the questions. So fun. Okay.
Okay, we have one hand. Dr. Tegene. Yes, Dr. Tegene. You're mute.
Yeah. Dr. Tegenik, can you unmute and speak if you're speaking? Yeah.
Okay, maybe Dr. Tegene has an issue with connection. Maybe we should go to
Hello?
Dr. Here we go. Hello, how are you?
Are you hearing me? Are you hearing me?
Yes.
How are you?
Yes.
Good afternoon.
Good
Okay.
afternoon.
Thank you very much for the excellent presentation. I have a couple of questions. One is
Yes.
already considering the etiologies of sepsis. We are discussing about bacterial etiologies. So what is your comment considering the fungal and the viral etiologies, especially when we have to consider, especially these low income countries? Because that could be one of the etiology, even though we are treating the bacterial etiology. And the second question is, usually in our setup from our practice, this newborns on broad spectrum of antibiotics and for long period of time, especially in our setup, we make the diagnosis clinically, and especially sepsis with meningitis, we treat for 3 weeks, considering the common etiologies are gram negatives. So in that scenario, this product antibiotics can affect the normal flora of the newborn and could expose for hemorrhagic disease of the newborn. So we are usually using the vitamin K till they complete the
You're breaking, Dr. Tegene. It's breaking. Can you hear me?
Yeah, I can hear you.
Yes, I've completed my. Yes, I finished my questions. 2 questions.
Oh, I'm not sure I understood completely. First was more a comment, is it, on the etiologies of sepsis?
Can I repeat?
Do you think you could
Hello?
write? Do you think you could write in the chat so we'll be able to understand fully? Because you were breaking.
Okay.
Thank you.
Dr. Sadika.
Hello, good afternoon. Can you hear me?
Yes.
Yes.
Okay. Thank you, Flavia, for your excellent presentation. So I have one question regarding the assumption of the possible bacterial pathology in case of a baby who is delivered at home, which frequently occurs in low-income countries, but later on, by 72 hours, get admitted to the hospital for some morbidities. So should we also follow the same antibiotic protocol if we want to cover early sepsis for the morbidities baby get admitted? This is one question. And the next question is, you have very beautifully shown the use of antibiotics. Many of times that is not in fact indicated in the right way. The common cause of such antibiotics, in our experience, we see that the babies are not hemodynamically stable many of times, and it is very difficult to prove this instability the other than causes other than sepsis. So in that case, we need to have a extended period of antibiotics. So what is your suggestion? Because we don't have the bedside echo or many other facilities to prove that this derangement might not be contributed solely by the infection. So what should be your suggestion in this regard?
Thank you, Dr. Sajika, for these questions that are very relevant. Considering the first question about the baby that's born home and comes to the hospital after 72 hours, this baby would have, by definition, a late onset sepsis community acquired because it's past 72 hours, but it's a community bacteria. Community bacteria usually is better than hospital bacteria. In most of the communities, they are less resistant, mostly. These drugs that have been chosen for treating neonatal sepsis, they still cover community bacteria. These drugs that are in the WHO guidelines, and they are still the drugs that we would recommend for this baby. If you're suspecting meningitis, of course, it would not be, it would be a little bit more, as we saw, but benpen or amoxicillin, benpen when you don't have amoxicillin, and gentamicin would be still the drugs of choice for this baby. Now, many centers, they will have different guidelines, and many countries, they might have their own guidelines because they might have guidelines that are based on their own ecology, and this is what would be the best. So these guidelines here are guidelines for when you don't have a guidance that is national guidance. Of course, if you have a national guidance, this would be the best to follow your national guidance. Concerning the second one, and a baby that has hemodynamic instability, this is a very good question. Babies, this is one of the best predictors of sepsis in preterms, basically, hemodynamic instability. So a baby that has hemodynamic instability, that's a preterm, and that you don't know how to explain otherwise, definitely, sepsis is the first thing to think about. And again, even if this baby doesn't have history, it's a preterm baby with hemodynamic instability. So this is a extremely high risk of sepsis if you cannot prove, if you don't have any tests to do. Definitely, I would agree with you on treating this baby through the whole course of treatment, basically. I hope I answered the question.
Thank you. Thank you.
Thank you. There is Maria.
Yes, thank you so much, Flavia, for that excellent presentation. There's no doubt neonatal sepsis is one of the biggest challenges we have in developing countries. Now, my comment, although you have partially responded to it in response to the last question, is the recommendation of the antibiotics to be used for sepsis as first line. Ampicillin and gentamicin is the WHO recommendation, but in our own environments, these antibiotics hardly work for us. I live and practice in Nigeria, and there's a high level of resistance to those antibiotics. And that's why, even from the chart that you presented, it was obvious that many at times we have to change to a second line antibiotic. So, yeah. So I don't know, would there be a consideration for review of these guidelines, or what recommendation does WHO give? Because many people tend to rely on the WHO guidelines, but if those drugs are resistant in a particular environment, what do we do? You know, and there was also something that interestingly caught my eyes, which is new to me, when you were talking about the parameters for diagnostics, or at least a guide, and you were talking about the full blood count, the white cell count of less than 1,000. What I used to remember was less than 4,000. So thank you for bringing that out. It's something that struck me as new. But what about other parameters in the full blood count? Are they still relevant or not relevant? Like the neutrophil lymphocyte ratio, like the mini ESR? Are they regarded as important guides, or they're no longer considered important? Thank you so much. Over.
Thank you. Thank you so much for your questions. For, again, very relevant. Again, each country is different, and each country might have each site, even not only country, each hospital, each community might have their own ecology. And AMR, we didn't go deep on this here. Of course, AMR is growing very, very fast. The more we use antibiotics, the more we increase the pressure of antibiotics, which is a lost in all age groups and also in animals. In the environment, this increases bacterial resistance, and we end up having common antibiotics that are not effective anymore. So again, if you have local protocols that have been developed based on your hospital, you should use your local protocols based on your own ecology. These are general guidances for when you don't have this kind of data, when in countries that don't have this kind of protocols. Considering the full blood count, yes, full blood count is very interesting, again, because it's the average of normality goes from 4,000 to about 25,000 in the first day of life. So 4,000 would be what is abnormal. So you're right, 4,000 is leukopenia, but it's not predictive of sepsis. So this value of 1,000, it's based on several studies and several reviews, and this is the reference for all of this here is this guideline for management of infections in preterm neonates from American Academy of Pediatrics, and you can find the link here, but you can also find in many other sources in the literature. So it's low full blood count leukopenia would be less than 4,000, but only when it's less than 1,000 would be at increase the risk of sepsis, basically, would maybe mean something. That's what I was meaning here. And the IT ratio, so immature to total neutrophils of 0.25. Voila. Or leukocytosis more than 50,000. And the normality would be border 25,000 in the first day of life, after it goes down very fast. But this would be what would be able basically to predict a little bit infection. Yeah. I think there is somebody else. We can take maybe one more and then you go to the next guidelines, next job aids. And there are some questions in the chat also, right?
Yeah. I think there's
So,
no hands up. I think Dr. Sadika has already spoken.
All right, so we can go to the chat.
Yeah. Yeah.
So I think I can
Dr.
see.
SM Khalid is asking how often should we change hand gloves during handling neonates?
Oh, that's a good question. So this is there are a lot of local protocols on using gloves. Basically, what should be done specifically is to do hand hygiene before touching neonates, right? And the question is changing diapers, is it? How often? During handling neonates. So the most important
Just
during
hand
handling
gloves, yeah.
neonates, yeah, is to perform hand hygiene. Of course, if you're using gloves, if it's a local protocol to use gloves, the idea is just to do hand hygiene before putting the gloves on. That's what's important, basically. And then again, if you are touching the diaper, you're not going to touch the mouth of the baby, so you have to wash your hands. But this is, again, 5 moments of hand hygiene. So you are going to change your gloves every time you need to perform hand hygiene based on the 5 moments of hand hygiene. I think Suman has something to say.
Hi, I just wanted to come in on the previous question of the very low counts and ANC and total counts less than 1,000. Please note that these are for high specificity. And therefore, when we look at sepsis, there's no single magical test which tells us whether there is sepsis or not. And a lot of people therefore go for a sepsis screen, and we need to take in clinical factors, risk factors, these tests, and only then decide on the course of antibiotics. Less than 1,000 total count or ANC would be severe sepsis. So the specificity of these things will be very high, but the sensitivity of it, both 50,000 or less than 1,000, would be quite low. So please look at the baby as a whole and not just single tests. And therefore, you have these barrage of septic screens, which considers counts, CRP, and other things together, and only then decide on the course of antibiotics. I just had one more suggestion for our friend from Nigeria. I agree with you in the real world conditions, especially in LMICs, the sensitivity to ampicillin and gentamicin may be low, and you're sort of worrying what to do. So at least in your level 3 places, it would be good to have your own antibiogram. And that antibiogram from a level 3 setup in, say, in Nigeria, maybe from Professor Ade's place or so, could help you in guiding the choice of antibiotics in the other places across Nigeria. And therefore, like, for example, my unit, we look at all our cultures year on year, and every year, along with Christmas, it's also a time to decide what would be our first line of antibiotic. Because it is empirical, you don't have blood cultures then, and the empirical antibiotics are used very much, in the sense, even at the risk of sepsis, you tend to use it. So I just wanted to share that we are using single drug amikacin for the past 3 years to ensure that we don't overuse other antibiotics. And it has worked well. And what is more important is that we have stopping orders. We stop antibiotics by 48 hours if there is no growth on the culture. Because if there is growth, it would flag within the first 48 hours, especially when we are using blood cultures like Bactec. So my request is the mentors who are working in level 3 places, please look at your antibiogram or develop your own antibiogram, which would help your whole country. Thank you. Back to you, Marianne and Flavia.
Thank you, Suman. Flavia, over to you. I don't think there's any more. Let me just check the chat.
Right. So maybe I should just go through this one, and then we can treat any other question after that. So we also have made job aids for the management of other common conditions in neonates. So I'm just going to go through that quickly. So this one is neonatal seizures. So we talked about meningitis. So what if the baby with meningitis has seizures? So we have this job aid. So basically, it's a 1-page job aid. Identify seizures. So we're describing the kinds of seizures. Tonic seizures are rhythm jerking that persist despite gentle restraint. Very common, neonates. Tonic seizures, sustained posturing, focal or generalized limb stiffening. Subtle seizures can only be abnormal eye movements like staring or blinking, oral automatism like chewing or sucking or drooling, limb movements like rowing, cycling, stepping, and autonomic signs like apnea. Myoclonic seizures are sudden brief involuntary jerks, less common. Identify and treat underlying causes. So first thing, hypoglycemia. We say this for not only for neonates, also for any child. Think about hypoglycemia, check glucose and treat. If low, before treating the seizure. If glucose cannot be measured, give empirical glucose, IV, 2 milliliters per kilo, it's 10% glucose. Meningitis, lumbar puncture, treat with antibiotics. If not possible, if baby is unstable, treat empirically if signs of infection. Hypocalcemia and other electrolytes can also cause seizures. So measure and treat if low, if possible to measure. So the main cause of seizures in neonatology worldwide is hypoxia ischemic encephalopathy, HIE, in birth asphyxia. Suspect of HIE when any acute perinatal event, for example, abruptio placenta, cord prolapse, severe fetal heart rate abnormality, severe bradycardia, or a complete abnormal CTG, or APGAR less than 6 at 10 minutes, or continued need for resuscitation with positive pressure ventilation. Cord pH less than 7 whenever the cord pH can be done, and base deficit of 12 whenever it can be done. So a baby of HIE is high risk for seizures. This is just to flag that. Do not give prophylactic phenobarbital in HIE without seizures. Do not attempt non-servo controlled cooling, but keep strict normothermia. So in these babies, we know that non-servo controlled cooling is harmful, where hyperthermia is also harmful. So basically normothermia will be what can be done whenever servo-controlled cooling cannot be done. And this is neuroprotector. Other investigations, so EEG whenever possible to confirm clinical seizures, whenever available, in imaging to determine prognosis only. So treatment, antiepileptic drugs, basically first line is phenobarbital, a dose of 20 milligrams per kilo once IV, to have loads of 10 milligrams per kilo may be given if seizures persist. Maintenance dose of 24 hours after load is 5 milligrams per kilo per day. If seizures persist, after giving 2 half loads and the loading dose, so benzodiazepine, diazepam, midazolam, or phenytoin, or lidocaine, as per local guidelines. So usually there is a local guidance on that. For difficult controlled seizures, consider pyridoxine. So this would be, if available, basically, when you try all the steps and it's not solving the problem. So when discontinue the treatment, basically, seizure-free more than 72 hours with normal neuro exam, a normal EEG, stop antiepileptic drugs. If there is one single antiepileptic drug, we can just stop without tapering, so don't need to reduce the dose, just stop. If there are multiple epileptic drugs, stop one by one, and phenobarbital is the last one to be stopped. So this is basically basic WHO guidance, and for whenever you don't have a protocol for seizures, so this is a guide for neonatal seizures in the CSIR facilities. We also have a guide for jaundice. So this is it's just also one page job aid. We define jaundice, yellow discoloration of the skin and mucous membranes due to elevated serum bilirubin. If untreated, unconjugated bilirubin can cross the blood-brain barrier and affect the brain, leading to cerebral palsy and sensorineural deafness. The first treatment is phototherapy, which helps convert bilirubin into forms that can be safely excreted. So phototherapy would be the first line treatment for jaundice. And then here we have monitoring and when to measure bilirubin. Visually assess, we can also do transcutaneous bilirubins as a screen of babies less than 35 weeks or more than 35 weeks or more than 2 kilos. And how to measure cerobilirubin in babies. So we have a guide for TCB here, of when to perform SPR in the first 3 days of life. Then we have the treatment thresholds for phototherapy in more than 35 weeks and in less than 35 weeks, and for exchange therapy also. Some messages on phototherapy, how it works to protect the eyes and to ensure a maximum surface of skin. We have to have a maximum surface of skin exposed to make it work. It works on the skin. But we have to keep the baby safe at a safe distance of lights. And then how to monitor every 12 to 24 hours, stop, then we have values to stop based on the serum bilirubin, always based on the serum bilirubin. And repeat the serum bilirubin after stopping phototherapy because rebound, as all of you know, is very common. And whenever Jones persists more than 2 weeks, to check both direct and indirect bilirubin to exclude cholestasis. So during phototherapy, some of monitoring, keep temperature, monitor hydration, breastfeeding. Don't forget, breastfeeding can be done during phototherapy. So please don't stop feeding the babies, and the baby that can suck can continue sucking briefly during phototherapy. Keep the machine clean and always clean after use. So this is very important for the staff, especially for IPC matters. And apnea. So apnea is also something that is very common in preterm. So we don't have caffeine everywhere, but whenever we have, so this can be used. So definition, non-breathing for more than 20 seconds, plus or less bradycardia or desaturation. Risk by gestational age. So we have a higher risk less than 32 weeks. So we recommend starting caffeine for everyone whenever available. And more than 32 weeks and less than 37 weeks, moderate to low risk. We give caffeine if the baby has apneas. If apneas occur and does not resolve quickly, so gentle tactile stimulation does not resolve, there is a severe bradycardia, of course, start bag and mask ventilation. So if the baby is not responding to tactile stimulation, don't waste much time stimulating the baby. So start basically resuscitation measures. Of course, before bag and mask ventilation, open the airway and then start bag and mask ventilation. Common triggers of apneas. So to exclude if a baby suddenly increases apneas regarding gestational age. So airway obstruction, very, very common. These babies are very small and they just by flexing, they can block the small airways. Hypothermia, overheating, sepsis or infection. We already spoke about it. Anemia, hypoglycemia, hypocalcemia, IVH or seizures, drugs, reflux. So treatment for apnea, always start caffeine. Basically have loading dose of 20 milligrams per kilo and then a maintenance dose 5 to 10 milligrams per kilo per day, once or twice a day. And we stop caffeine about 24, 25 weeks of corrected age if baby is stable. After stopped, we have to monitor the baby about 5 days and only discharge when the baby has at least 48 hours without apnea. CPAP. Also, CPAP can also help for obstructive apnea. Some babies might increase apnea when you stop CPAP. So if you stop CPAP in a very small baby and the baby starts having apnea, so just consider that can be a failure of CPAP, and you can restart CPAP in these cases and see if the baby gets better. Maintain normal temperature. So fever and hypothermia, they also worsen apnea, and monitor pulse oximeter if available, and optimize head positioning always to keep the open airways. If caffeine is not available, optimize treatment, position, CPAP, temperature, and monitoring again. So if caffeine is not available, all of the rest optimize. And continue KMC. Actually, KMC reduces apnea. Voila. We are just in time. So I think what I can do is to keep answering the questions from the chat online. And if there is no burning question, I think we would be able to stop this session just in time. Is there any?
Have we responded to all the questions in the chat?
No, that's what I'm saying. So I think we can. We can respond to the questions in the chat. So I don't know how many questions. How many questions you have in the chat?
There are a few, but we could rapidly go through them.
The sprint.
Pardon?
Okay, let's go.
You want to go, Flavia?
Yeah, I'm trying to find them because I cannot see. I'll stop sharing.
Yeah, you can stop sharing.
Thank you. So, does it mean we are downplaying on the role of acute reactive protein CRP of procalcitonin in diagnosis of sepsis? Yeah, so diagnose CRP and procalcitonin, they don't make the diagnosis of sepsis. They are very bad for that. So they can help on excluding sepsis only, but not when you start treatment. So basically it can be used whenever you don't have blood culture after 36, 48 hours when they are serially negative, but not to diagnose sepsis. They are very, very bad in predicting sepsis. In a premature newborn, shows no growth on blood CS, and the baby has to be kept in a busy NICU, having high sepsis prevalence. Should we continue antibiotics? So this is a question about prophylactic antibiotics, right? So if the baby has a good blood culture that is negative and the baby is well, you stop antibiotics basically. And if the baby becomes infected, we will do the best basically to reduce prevalence of infection in this unit. So we have to do a lot on IPC basically. And this baby just have to be careful with hand hygiene and all the IPC bundle, feeding, kangaroo mother care, which will reduce the risk of infection. So we just do everything to reduce the risk of infection, but we don't continue antibiotics as prophylactics because this will increase the risk of infection in this baby and will also increase the risk of resistant infection, basically. So when do you think the appropriate time to send CBC, CRP, your recommendation? So again, this is it can be done as part of the infection screening, can give you a rough idea, but will not make diagnosis. So the CRP can be used as a serial approach. So you can do in the first at birth, and you can do about 36 hours. If you can do two times, it would be great. If you cannot do at birth, you can do at 36 hours. So the latest, the better. Basically, you can do at 12 or 36. So there will be different approaches, but basically, you know that 2 serious CRP and actually 1 CRP at 36 hours that is negative has already itself a very high negative predictive value. So yeah, if you can only do once, you can do at 36 hours.
I just wanted to come in here. We send a CRP and a CBC. We wait at least for 6 hours. We don't send it at birth. We give some time. But like Flavia is saying, if you can have 2 which are negative, then you can be sure that there is no sepsis. So it helps to rule out sepsis and not really rule in sepsis. But I would also like to say in late onset sepsis, you know, when we get babies who look septic, we do find their CRP is quite high. And in those babies, we send it as soon as they come in. We don't wait for a time because they are symptomatic. They have had time for the CRPs to rise. And in them, we definitely have found a correlation between sepsis and blood culture positivity and in late onset sepsis. Early onset sepsis, CRP hardly has any role.
Yeah, so CRP and PCT, they have a better predictive value for late onset sepsis, both of them, and but it's still very low. So, but it's more useful, but they still don't make diagnosis. So remember to always do blood culture still. In low-income countries like us, where poor ANC for treating RDS, should we consider antibiotics? Again, even if there is poor ANC and you don't have any risk factor before birth, so you have a lady that will have a cold cesarean section that's well, and you have membranes that are intact, and you have a baby that is basically healthy intrauterus and that doesn't have symptoms at birth, there's no reason to give the baby antibiotics. And if you can explain the respiratory distress otherwise, again, by cesarean section and no labor, and a baby that gets better very fast, it's very unlikely basically to be a neonatal infection. You need blood culture. I think this one is answered. No, you need blood culture for antibiogram level 3 university.
Yeah, I
can get on. Yeah, that's what someone said. Yeah, okay. There is one here. Good afternoon. Yeah, Dr. Kanda. I'm working at Bangladesh hospital. Shinto Hospital, I have an observation that we are usually finding difference in organism being detected. Yes, definitely, in early onset sepsis and late onset sepsis. We are getting Acinetobacter, Klebsiella, Pseudomonas, E. coli, mostly no GBS. So choice of antibiotic is nearly the same in both cases. You have no difference. Right. Is there any suggestion for us? So you have your own. Someone she already replied. Okay, yeah, you already have your own ecology. You know which bacteria you have, and you know what's their sensitivities. So definitely, you can have your own guideline that's targeting these bacteria.
I just wanted to come in again on this. There are two aspects here. One is it has been found that in like our part of the world, even the cervical flora of women may harbor these MDR bugs. And they are gram negative, and there are studies which have shown that. So that could be the reason why we have early onset sepsis with these bugs, which are typically late onset. But the other thing that I would like you all to look at is your labor room practices. Because when we say early onset, it need not come only from the mother. A lot of times it is what we do in the labor room. Because sometimes I see in my own unit, people are all very great in hand hygiene in the NICU. But the same 1,000 grammer, when they go to receive, they may not do hand wash. So I think it's important for us to look at what we are doing in the labor room, whether we are following all the infection control practices. And that also may be one of the explanations for this. So this just means that we have to tighten our infection control practices. Yeah.
Definitely.
There was
Right,
something
thank you,
on
Lawrence.
viral and fungal etiologies as a cause of sepsis. What is your
Right.
comment on viral and fungal?
So they exist. So you can have fungal infections, most commonly late onset sepsis in very, very small babies that have parenteral nutrition, that have catheters, that have skin breaks. And this can be also done by staph colonization. They can also have infection from the mother, maternal colonization with candida. So, but it's usually very, very small preterm babies that are at higher risk, small, less than 26 weeks, and small, less than 1 kilo, but even smaller, less than 500 grams. But the babies less than small than 1 kilo, there are some studies even on trying to give prophylactic antibiotics to these babies. So this is recommended in several sites. So what we know now about prophylactic antibiotics for Candida is that it can be done whenever you have a high prevalence of Candida in the unit. So which is a case in many places. In both places I work, we do prophylactic fluconazole for extreme preterms, either for extreme preterms, either for less than 26 weeks. But this is based on the local prevalence, basically, of Candida. And so the best way to see is to have a look at the population itself. It's not a WHO recommendation, but it's something to think in a very small baby that you are treating for infection and is not responding, basically. In Candida, you can also have very high leukocyte count, or these leukocyte counts that are more than 50,000. And in extreme preterms, like less than, especially 26 weekers, but again, they're very, very small, you can have red dots on the skin. It could be a sign. There are a few papers on that, red dots on the skin and white dots on the placenta at birth. They are very highly correlated with Candida. Yes, and the viral. So viral is, unlikely to be presented as early onset sepsis, but herpes can. So a baby can be born from a mother with herpes and present with typical herpes, and it can be just a baby. When they are preterm, they will not always present skin lesions. So it's important to know the history, know if the mother had herpes. Also after delivery, so after in this late onset sepsis, so you can have a whole range of viral sepsis. Again, especially in preterms, they will have more severe viral sepsis. So history is extremely important to exclude these parts. But either way, they are less common, much less common than bacterial sepsis. And basically history is very important. And the population that will have more severe signs will be the small preterms.
And just to add to it, we are seeing a lot of RSV, but they're usually present with respiratory infections and in
Yeah.
preterm sometimes like sepsis. The fungal infection is also a result of high use of antibiotics. So if we start curtailing on antibiotics, our fungal infection rates come down. And third thing, just because you have high fungal sepsis in your unit, prophylaxis may not help. Way back, we had the same issue, and when we looked at it and we actually published this. We found that the fungal infection we had in the unit was glabrata. This was when I was doing my post-graduation, and glabrata is inherently resistant to fluconazole. So
Ah,
therefore, you should not only know that you should have a high incidence, you should also know what is the bug that you have and what is its sensitivity pattern, and only then think of prophylaxis. So one of the most difficult areas, and I think we can go on and on, is sepsis. We don't have all the answers, but one thing that we definitely know and which is very strong is that it's preventable, and we must do everything that can prevent sepsis. Otherwise, sepsis, once it sets in, it's really, really challenging. Thank you.
Thank you. So we are 10 minutes past, so I think we can stop our session now. I will still go through the whole chat, see if I missed anything, and I'll make comments there. Can all keep commenting. And thank you very much for your presence. Thank you very much for your time. And we are going to have another session, not next week, the week after, which will be the last seminar session on GSC. Thank you so much. Have a lovely day.
Thank you.
Thank you.
Thank you, Flavia. Thank you. Thank you,
Flavia, I
Flavia.
love
Thank you, Mary.